Hello everyone, hope you're all doing good. We are going to continue our discussion on leiomyoma in this part. First, let us discuss about the clinical features. %50 leiomyomas are asymptomatic and they are usually diagnosed incidentally. If you ask about the menstrual disturbances that will occur with fibroid, some women may have abnormal uterine bleeding or intermenstrual bleeding. So, that will be seen in 30 to 40% of the women. Okay. Now, let's see why these menstrual symptoms are occurring in a woman with fibroid. Number 1, there is increase in endometrial surface area. Number 2, there is increase in vascularity of the uterus. Number 3, it interferes with the vascularity of uterine contractility. Clear? Right. Then, some women can also present with anemia, that can also present as weakness or palpitation. Some women can have dysmenorrhea, dyspareunia, pelvic pain also, and this pelvic pain can present as low back pain, or it can even present as an acute pain in case of torsion or red degeneration. Okay. And another type of presentation you can have is pelvic mass. The pelvic mass can arise up to more than 20 week size, and this is mostly seen in women who are thin. In some cases, because of the enlarging fibroid, there will be pelvic pressure symptoms as well that will lead to urinary frequency. There can be incontinence of urine or retention of urine. It can also result in constipation. That means difficulty in evacuation. Okay. Some women can also present with infertility, and leiomyoma as such is responsible for infertility in 2 to 3% cases. Okay. Why infertility in these women? Because a leiomyoma can give rise to tubal occlusion. There can be impaired uterine contractility. It interferes with implantation. This I have mentioned in submucous leiomyoma discussion itself. And yes, there can be displacement of the cervix from its normal anatomical position. Okay, so these are the causes of infertility. There can be tubal occlusion, there can be impaired uterine contractility, it interferes with the implantation, especially the submucosal type, and there can be displacement of the cervix as well. Yes. Next one, we are going to discuss about the complications that can happen with fibroid. Okay, complications include hemorrhage. Already we have seen because of AUB, they can also present with anemia. There can be degenerative changes which we have already discussed, and sometimes if it is a subserosal pedunculated fibroid, torsion of the subserosal fibroid can also be there. There can be chances of intraperitoneal hemorrhage as well, especially when there is rupture of vessels. Okay, when there is rupture of vessels from submucosal fibroid, and then infection is also another possibility, especially when it happens in submucosal variety, and increased chances of infection of a fibroid is also seen in the puparium. There can be chances where a leiomyoma can change into a malignant tumor. Okay, leiomyoma is a benign tumor. Okay, so it can anytime change into leiomyosarcoma. Okay, which is a malignant tumor. So it is leiomyosarcoma. This change can happen in 0.2% of the cases, and especially when the woman is post-menopausal. What happens means there is increase in size, okay, increase in size suddenly, and the tumor becomes soft and it looks yellowish grey in color. Clear? Sometimes a fibroid can also lead to uterine inversion, especially when it is a submucosal large fibroid polyp, and it can also be a cause of obstructed labor as well. Clear? So these are the complications of fibroid. Let's discuss about the differential diagnosis of fibroid. What are the differential diagnoses you have to keep in mind? Differential diagnoses include, first, the most simple one, full bladder. Second one, pregnancy. The next one is an ovarian tumor. Fourth one, it can be a large tubo-ovarian mass, and then there can be a large chocolate cyst as well, that is endometriosis. We can even have a mesenteric cyst, adenomyosis, Coats peritonitis, that is tuberculous peritonitis, ascites, renal lump, splenic enlargement, retroperitoneal lymphoma, gastrointestinal lump, or even a high splenic enlargement, or any retroperitoneal mass like lipoma or lymphoma as well. Okay. So, these are the various differential diagnosis of fibroid uterus: full bladder, pregnancy, ovarian tumor, large tubo-ovarian mass, large chocolate cyst, mesenteric cyst, adenomyosis, Coats peritonitis, ascites, renal lump, splenic enlargement, retroperitoneal lymphoma or lipoma, gastrointestinal lump, high splenic enlargement. Sorry, I have repeated this. Yeah. So, this is one of the common questions that is used in your Viva also. Okay. Yes. Next one. Let us see the investigations which you will offer for a woman with fibroid uterus. Okay. You have to check hemoglobin to rule out anemia. Then you will use ultrasonogram, abdomen and pelvis. So, with this you will be able to see the size of the fibroid, the site of the fibroid, the number of fibroids as well as the types of fibroids as well, which will include submucosal, subserosal or intramural. Okay. And then you can offer them saline infusion sonography, especially in diagnosis of submucous fibroid. You can even offer them hysteroscopy. This can be both diagnostic as well as therapeutic in case of submucous fibroid, where you can go for resection of the fibroid as well. And finally, laparoscopy in case of infertility, especially to rule out the tubal factor. Then the additional investigations needed will include intravenous pyelography in case of broad ligament or any large fibroid. Okay. Here it will lead to dilatation, kinking or alteration in the course of ureter. CT or MRI can also be offered when diagnosis done by USG is not confirmatory, as well as MRI can give the differentiation between a fibroid and adenomyosis. Clear? So, this is all the investigations you will do for a patient with fibroid. Now, let us discuss in detail about the management. So, for managing fibroid, options will include either you can give them expectant management or medical management. Even a radiological intervention can also be tried, and finally the most invasive surgical management. Okay. Now let us see how and when you will offer expectant management. So, expectant management is usually given for asymptomatic fibroids, especially when it is a single fibroid, or even in multiple fibroids when the size is less than 3 centimeter. And in these cases, at least annual follow-up should be given by using ultrasonogram. Clear? Yes. And when you want to treat this asymptomatic fibroid, you are doing an annual follow-up and there is no problem. So, when the intervention will be actually needed. So, treatment is actually needed in a symptomatic fibroid, and then even in an asymptomatic fibroid, when it is more than 12 weeks size, when infertility is present, okay, when the problem leads to infertility, or that was a rapidly growing fibroid and a fibroid which is causing pressure effects. Okay, so in these cases you have to give intervention soon. Okay, asymptomatic fibroid, asymptomatic fibroid which is more than 12 weeks, when infertility is present, when it is a rapidly growing fibroid, that means the change is going to be a malignant one, and a fibroid which is causing pressure effects, right? Yes. The next one is, let's discuss about the medical management you can give for patients with leiomyoma. The first and foremost thing you have to do in these women is to correct anemia. Okay, so this can be done with iron tablets or infusion. You can even give PRBC transfusion. And there are two options to manage fibroid. You can choose a hormonal management or non-hormonal management. Okay, let's see about the non-hormonal management first. Non-hormonal management means you will give NSAIDs, especially you can give mefenamic acid, and you can give tranexamic acid as well, that can be given at a dose of 1 gram TID for 3 to 5 days. Then let's go for hormonal management. Here we can give combined oral contraceptives, where we can choose to give a COC with low estrogen, and this will help in reducing the heavy menstrual bleeding that is happening. And you can also give them levonorgestrel IUS, that is having progesterone. Okay, so this also reduces bleeding, right? And you can also give anti-estrogen as well as anti-progesterone drugs, because I have told you already in the pathology that it can happen due to hormonal effects also, and both estrogen and progesterone are responsible for the growth of the leiomyoma, but estrogen is going to be the most important hormone. But however, for treatment we can use both anti-estrogen and anti-progesterone drugs, right? So, anti-estrogenic drugs will include GnRH agonists, especially leuprolide acetate, that can be given at a dose of 3.75 milligram IM monthly for 6 months. Okay, when you give leuprolide like this, there will be reduction in the size of fibroid by 30%, there will be reduced bleeding, and this option can also be considered preoperatively to reduce blood loss. Okay. So, ideally if you plan surgery 2 to 3 months before this, you can start giving GnRH agonist. Clear? Yes. You can even give GnRH antagonist example is elagolix, which will reduce 29% of the volume of fibroid. Okay. Another option is aromatase inhibitors like letrozole, and then you can even give danazole, but nowadays this is not right because there are so many side effects, right? Next category of drugs you can give is, yes, anti-progesteronic drugs. So, anti-progesterone drugs, here you can give mifepristone, that is Ru486, that is given at a dose of 10 to 25 milligram daily for 3 months. It will cause amenorrhea. There will be 90% reduction in the heavy menstrual bleeding, and there will also be reduction in volume of the fibroid. Clear? Second drug is ulipristal acetate. So, this drug is a selective progesterone receptor modulator. Okay, this is SPRM, that is selective progesterone receptor modulator, which can be given at a dose of 5 to 10 milligram daily for 12 weeks. This will also bring amenorrhea, decreased menstrual bleeding, and it also reduces the fibroid volume. Clear? Right. Now, let us talk about the advantages and disadvantages of medical management. Okay. Medical management has a lot of advantages and disadvantages. While giving medical management, the advantages include anemia is corrected, the bleeding is reduced, size decreases, so that surgery is easy, and it also reduces pressure symptoms. Okay, so these are the advantages. Okay, let's see the disadvantages. So, disadvantages of medical treatment is, number 1, definitely there will be side effect of the drug, and it can be used for a limited period only. Cost of the drugs will also be worrying. There can be failure. Tumor can regrow after stopping the drug, and however, surgery can be needed. Okay. It's not that medical management will be the final management mode for fibroid. Okay, anytime surgery can be needed, right? Now, let's talk about the radiological intervention. Okay, so radiological interventions. The first one is uterine artery embolization. Okay, uterine artery embolization. This is usually done by an interventional radiologist. Okay, so done by an interventional radiologist. Before doing this procedure, pregnancy must be excluded. Polyvinyl alcohol particles about 500 to 700 millimeter will be injected in both uterine arteries, and the particles are placed more towards the normal myometrium. Okay. So, what happens means the fibroids that are now supplied by the end arteries will undergo necrosis. Clear? So, this is how uterine artery embolization is done. So, these are the polyvinyl alcohol particles that are injected, and finally when it comes to the fibroid, it will be bringing out an end artery that will be going for a necrosis of the fibroid. Okay? Yes. Next one is MRG FUS. Okay, what is this MRG FUS? Yes, that is magnetic resonance image guided focused ultrasonography. Clear? So, in this procedure, we are using a high intensity ultrasound, especially at a precise area. Okay, precise area means where the fibroid is exactly present, and this will lead to increase in temperature, which will cause coagulation necrosis of fibroid. Clear? And the next one is surgical management. Repeating. So, let's see a picture where they repeating. So, this is a picture where MRG FUS is done. Okay. So, they are giving a focused ultrasound energy using an ultrasound transducer on the fibroid. Okay, present here. So, this will be leading to coagulation necrosis of the fibroid. Right? Yes. Now, let's discuss about the surgical management of fibroid. Indications of surgical management includes persistent symptoms in spite of conservative methods. Then, if it is a huge fibroid. Okay. So, what are the surgical options we can have? Number one, we can have a myomectomy. Second one, a hysterectomy. Third one is endometrial ablation. Okay. So, first one is myomectomy. Okay. Let's see what are the Let's see what are the indications of doing a myomectomy. Okay. So, indications of myomectomy means if she is a young woman who is desirous of fertility, or when there is a submucosal myoma. So, submucosal myoma can cause recurrent pregnancy loss. Yes. Next one is, what are the routes of offering myomectomy? Myomectomy can be offered through an abdominal laparotomy, vaginal route, hysteroscopic resection, especially of your submucosal type of myoma, then via a laparoscopy or even a robotic procedure. Okay, so these are the various routes, right? Let's see when a hysteroscopic resection of a fibroid can be offered. It is mostly offered in a submucosal myoma when the size is less than 3 cm, and this can even be combined with endometrial ablation. Okay. Now, let's see about laparoscopic myomectomy. So, laparoscopic myomectomy always laparoscopic procedures are preferred when compared to laparotomy. Okay, and this can be done especially in symptomatic fibroids where child bearing is a problem. Then it may even need morcellation. Okay, that is, the fibroids will be cut into smaller pieces and it will be taken into an endo bag. Okay, and then we can even offer them laparotomy, that is nothing but open myomectomy. The skin incision we can give here is a phalansteal incision, and if it is more than 14 weeks, offer them a midline vertical incision. Okay, you can go for exteriorization of the uterus, so that you can go for a careful inspection of fibroid, and you can also rule out any other pathology if present. Clear? Yes. Now, how you will go with the uterine incision? In uterus, you can give a vertical incision on the anterior wall. This will help in enucleating the myoma as much as possible. Posterior incision is not given because if you give posterior uterine incision, there are increased chance of postoperative adhesions. So, we are not preferring it. Okay. Then there is a surgery called Boney's hood operation. This is especially done for posterior myoma, especially when it is large. A transverse incision on the posterior wall above the level of tubal attachment can be given, and the flap will be sutured with the lower part of anterior wall. Sometimes there can be a need of giving multiple incisions as well. Clear? So, how you will do this enucleation? Enucleation can be done sharp or blunt. Okay, sharp means we will be using scissors, blunt means we will use fingers. Okay, then you have to identify the feeding vessels and ligate it out. If the bleeding points are more, they are closed with 1-0 delayed absorbable suture for perfect homeostasis. Clear? Yes. Now, let us see what are the complications of myomectomy. Myomectomy complications include hemorrhage, trauma to the bladder, ureter, rectum and even bowel. Clear? There can also be chances of intestinal obstruction that can result as paralytic ileus, adhesions, rupture of the uterus can happen in subsequent pregnancy, or there can be scar endometriosis as well. Clear? So, these are the complications of myomectomy. And finally, we can offer them hysterectomy as well. And remember, hysterectomy is offered for women who are more than 40 years, who have completed family. Okay, and the other indications of performing hysterectomy include: number 1, when a fibroid is associated with malignancy and there are pressure symptoms which is causing so much discomfort to the woman, especially when she is 40 years old and she has a symptomatic fibroid and she chooses an option for permanent cure. Clear? So, route of surgery, as we have already seen, it can be total abdominal hysterectomy, total vaginal hysterectomy or total laparoscopic hysterectomy. So, among this, abdominal route, that is TAH, is preferred when the size is more than 14 to 16 weeks in size, or when it is a broad ligament fibroid or a cervical fibroid. In women up to 65 years, normal ovaries can be retained. Okay, normal ovaries can be retained, and removal of ovaries, that is bilateral salpingo-oophorectomy, can be needed in women who have a history of familial cancer or associated tubo-ovarian mass, or there is endometriosis. Clear? So, as I told, hysterectomy can be combined with bilateral salpingo-oophorectomy, and this is also helpful in preventing the ovarian malignancy. Okay, and at last I will talk about one intervention, that is endometrial ablation. So, this is usually offered for a submucous fibroid when it is less than or equal to 3 centimeter. So, next option is myolysis. Okay. So, what is myolysis? Myoma is punctured, okay, that will cause myoma necrosis, and the shrinkage can be brought by cryotherapy or laser. Okay. Next one is leiomyomas. So, this is an extra uterine smooth muscle tumor. Okay. But yeah, it is a benign tumor which has infiltrative properties as well. Okay. So, this can arise in a woman with myoma or who had a history of myoma as well. Okay. Yes. Next one is myxomatous erythrocytosis syndrome. Okay. So, in this syndrome, a patient with myoma can also have erythrocytosis. Okay. And then there is a syndrome called pseudomyx syndrome, where you can have an uterine fibroid, ascites, as well as pleural effusion also. Clear? So, yeah, with this we are completing the big topic on fibroid, and until we meet in the next video, take care, happy learning, and bye bye.